Hypertensive disorders of pregnancy. Hypertensive disorders of pregnancy have gone through a whole lot of different name changes. For decades it was called toxemia, and then we started to talk about preeclampsia, eclampsia. Then we called it pregnancy-induced hypertension. Sometimes you see gestational hypertension, which is slightly different, but it is one of the hypertensive disorders. Basically, they're all talking about the same thing. Here we have the 2000 classification that says, you know what, preeclampsia, eclampsia is different from chronic hypertension. However, some people with chronic hypertension get preeclampsia on top of it, so they have a combination. And then some people just have gestational hypertension, which is a transient increase in blood pressure. We're going to be talking mostly about preeclampsia. It's the most common hypertensive disorder in pregnancy. In a normal pregnancy, blood pressure increases in the first trimester. During the second trimester, the progesterones kick in. We have vasodilation, and blood pressure actually decreases. But by the end of the third trimester, blood pressure will have returned to its normal pre-pregnant level. In deciding if a woman has preeclampsia or not, we look at someone who has an increased blood pressure after 20 weeks of gestation, and there's also proteinuria going on. Edema in pregnancy is normal. It is not a diagnostic category, however, it tends to be worse in people with preeclampsia, and it especially starts to affect the face, puffy face. When people get real puffy hands and real puffy face and real puffy legs, we're going to start to worry. But a little bit of that is normal in a regular pregnancy. Now, the category of eclampsia is the same disease, except we've added seizure activity onto that. She's preeclamptic, and then she has a seizure, then we call her eclamptic. Characteristics of preeclampsia is a vasospasm, generalized vasoconstriction all over the body. Well, remember, the blood volume in pregnancy has increased. So something has to go. So you decrease the size by having vasoconstriction, and then you increase the the blood volume. You're going to have increased blood pressure. The body also reacts by squeezing the plasma out of the blood vessels into the tissue, so you see more edema that way. There's also an activation of the coagulation cascade because this vasospasm damages the blood vessels, and the little platelets and all those things try and fix it. So they're being used up just by the vasoconstriction that's going on. There's also an alteration in glomerular capillary endothelium. With vasospasm, there's a decreased perfusion to virtually all the organs, including the placenta. So we're looking at potentially a fetus getting IUGR and being exposed to chronic hypoxia and distress. The decreased renal perfusion causes a decrease in GFR. Serum creatinine, BUN, and uric acid all rise, and sodium is retained, so the urine output drops. Sodium retention leads to increased extracellular volume. There's a stretching of the glomerular capillary walls that allow the protein to escape into the urine. This decrease in plasma volume, the pushing of all the plasma out into the, well, not all the plasma, but a lot of the plasma out into the tissues, results in a hemoconcentration. And again, there's an activation of the cascade. When we look at the pathophysiology, I'm going to send you back to your text to look at the diagram in there. It's a pretty nice diagram. And I'm going to ask you, which organ systems are being affected when the patient exhibits complaints of hyperreflexia? Remember, we're looking at hypoxia because of vasoconstriction. So which organ system had to be affected for the woman to end up with hyperreflexia? Headaches, epigastric pain, visual changes, dyspnea, and convulsions. Sometimes the preeclampsia is so bad that we end up with what we call the HELP syndrome. Remember, vasoconstriction, tiny little blood vessels, damaged blood vessels. So these tiny little blood vessels, the red blood cells are trying to get through and they get damaged and they hemolyze. So you have hemolysis, which means, unlike before when we said there's a hemoconcentration going on because the plasma got squeezed out, now we're looking at a drop in the hemoglobin hematocrit because they're being damaged. This is a much more severe situation. We have elevated liver enzymes and low platelet count. Okay, let's go back to the mild form. Blood pressure greater than 140/90 is classified as mild preeclampsia. We're looking at proteinuria, we're going to do dipsticks for protein, and we're going to do a 24-hour urine collection. They may have edema, they might not, and whether they got edema or not, maybe she's got the disease, maybe she doesn't. It's not diagnostic. As she moves into the severe form, she's got a blood pressure greater than 180/110, oliguria, cerebral or visual disturbances, pulmonary edema or cyanosis, epigastric or right upper quadrant pain, impaired liver function, which means elevated hepatic enzymes, the AST and ALT, and thrombocytopenia. Eclampsia means there's a convulsion going on, maybe a coma. It can happen before or during labor, and it can also happen in the early postpartum period. Okay, this woman has preeclampsia. How do we know if it's getting worse? Well, increasing edema usually means things are getting worse. Headaches, getting worse. Epigastric pain, that's a sign that something bad's happening. That's a sign that we've moved along into a fairly severe case. Visual disturbances, decreasing urinary output. Aren't these all what we saw in this previous slide about severe PIH? Nausea and vomiting, bleeding gums, that has to do with we're using up the clotting factors, we're using up the platelets, disorientation, and generalized complaints of not feeling well. Think about it. Everything is hypoxic, including the brain. A lot of these symptoms come from cerebral hypoxia. Okay, hospital care. What do we have to do? Well, we have to monitor the fetus and the mother. This woman's going to have either constant fetal monitoring or at least have it happen a couple times a day. We're watching mom's blood pressure and her daily weight. Is she putting on more and more fluid? You know, as the kidneys can't excrete it, is she gaining fluid weight? We're going to do a daily evaluation of her headache, visual changes, and epigastric pain. Urine protein dipsticks. We're going to be following her CBC and platelets. And we're looking at her serum creatinine, uric acid, and liver function tests. Do they seem to be getting worse? As the condition worsens, she's going to be put on bed rest. Now we say left side is the best. Well, for whatever reason, it does seem to get best circulation if she's lying on her left side, but nobody can lay on their left side 24 hours a day. If they can't be on their left side, get them on their right side. Avoid lying on the back. We're going to encourage a high protein, moderate sodium diet. A low sodium or no sodium diet will actually make this worse. So it's a moderate sodium diet. Magnesium sulfate is the drug of choice, and what that is to prevent convulsions. That's all it does. There may be a very mild secondary effect of bringing the blood pressure down, but we primarily give it to avoid convulsions. It's a central nervous system depressant. We'll give corticosteroids. That's to help the baby's lungs, the fetus's lungs, mature, so when birth has to happen, we've got a child who can breathe. Fluid and electrolyte replacement and antihypertensives. So, she has a seizure. We call it eclampsia. What are we going to do? We're going to assess the seizure. We're going to put her on her side to prevent aspiration, have suction available to be used if needed, side rails up and padded, a magnesium sulfate bolus, maybe phenytoin. After the seizure, we are assessing the fetal status. How did the fetus get through all this? We're going to listen to her lungs. Did she end up getting pulmonary edema from this seizure? Did she aspirate? We're going to watch her fluid status. We're going to be aware that a coma may follow, and we're going to check for cerebral hemorrhage. People usually have hyperreflexia before a seizure starts, so we're checking her deep tendon reflexes fairly frequently. As the seizure starts, we're looking at things like the onset, the progress of the seizure, what parts of the body are involved, how long does it last, does she have incontinence as part of it, how does the fetus respond, and are we now having an abruption because of it? Because of the changes in pressure and blood flow, are we ending up with a placental abruption? And lastly, let's look at what happens in labor and delivery. These ladies quite often will have an induced labor. We are watching them day by day. Where is the fetus safer, inside mom or outside mom? We're looking primarily at what kind of blood flow is coming to the placenta. Is the fetus getting the oxygen it needs to continue to stay inside? They're going to have magnesium sulfate. We may end up with central monitoring, a CVP or an arterial wedge pressure. We're going to do I&O, and they're going to have antihypertensives.